and welcome everyone. This is a part of STEP's worldwide webinar series, and the recording will be available on YouTube and the website. My name's Jacqueline. I'm a volunteer for STEPs. I'm also a parent of a child with DDH. We have Miranda from STEPs in the background, who is doing all the technical side for us. And we're going to have an expert speaker, Joanna Craven, an orthopaedic surgeon who's currently undertaking a PhD at Liverpool University and Alder Children's Hospital. And we're going to answer some of the most common questions STEPs receives on this topic. So I'll hand over to you, Joanna, and you can tell us more.
Hi everybody, so thank you for attending this STEPS webinar. We're going to be talking about developmental dysplasia of the hip. My name's Jo. I'm an orthopaedic surgeon and I am currently undertaking a PhD in DDH. So a little bit more about me. So I went to medical school in 2012 and spent 5 years there before graduating. I then did 2 foundation years moving around different subspecialties, and I ended up at Alder Children's Hospital working in the orthopaedic department there. And so I came across children with DDH. I loved it. I got involved in research there and decided to undertake surgical training. So there was 2 years of core surgical training. Again, part of that was based at Alder Children's Hospital. And then I entered into my specialist orthopaedic training in 2021. And I'm currently undertaking a PhD at the University of Liverpool and with Alder in conjunction with my clinical training. And so today we're going to talk a little bit about what DDH is. We're going to talk about how we screen for it, what the treatments are generally and what the sort of focus of treatment is, and then a little bit about DDH research and perhaps how you can get involved. So what is DDH? Well, you will have heard lots of different terms, I'm sure. Developmental dysplasia of the hip, congenital dysplasia of the hip, which is sometimes abbreviated as CDH, clicky hips, hip dysplasia, and they all mean the same thing. But the current term that doctors are using and trying to standardize for people is developmental dysplasia of the hip, DDH. So DDH is relatively common and it affects about 2, possibly 3 in 100 babies. Now the most severe form, a completely dislocated hip, is much rarer than that, and that affects about 1 in 1,000 babies. But in order to understand what DDH is, we're going to go right back to the start and we're going to talk a little bit about what a normal hip joint looks like and the development a hip joint will go through as a baby grows into becoming an adult. So the hip joint is the joining of the thigh bone to the pelvis. The hip joint is commonly referred to as a ball and socket joint. So the top of the thigh bone here, there we go, forms a ball, and that's known as the femoral head. And that sits within this socket within the pelvis, and that's known as the acetabulum. And this infographic here is a sort of deconstructed version of this ball and socket. And what it shows you is that you get an increased range of movement with this configuration. So not all joints in the body are ball and socket. If you take an elbow, for an example, an elbow only bends and straightens, whereas a hip joint you can move sort of all round in a sort of 360, dependent on the constraints of your flexibility. And that increased range of movement is what allows you to do all of the different things you do in terms of squatting, walking, jumping, running. And in order for us to explain DDH, we're going to imagine that your hip joint is a perfectly sized tennis ball sitting in a perfectly sized teacup. So these are 2 medical illustrations. On the left-hand side here, we've got a normal baby's hip joint. And on the right side, we've got a normal adult hip joint. And you can see that there's some differences between the two. So this here is your socket, your acetabulum, and this is the socket on your adult side. And in a baby, you've got an area of cartilage in the centre of it and an area of cartilage at the side. And that's a sort of similar consistency to your nose in that it's softer, it's not hard like bone, and growing comes from these areas. And so, as I'm sure you can appreciate, a baby's hip is much smaller than an adult's hip. And this softer area allows that growth to happen. And you have growth plates sitting in these regions. And the same is true on the other side. So around this femoral head, you have a growth plate. And once you get to an adult, these have fused. So these have become complete solid bone the whole way round. And again, when we now go on to talk about DDH and how that's different, you can appreciate that the teacup is our socket and the tennis ball is our femoral head. So here I've drawn on your growth plates. So you've got one in the centre, one at the side, and one down in the femoral head. And over time, as you get bigger, the growth is coming from here, and that allows you to develop into this normal adult hip. So what is DDH? So this is a very busy medical slide. And what you've got is the normal hip. You've got an ultrasound scan, which I'm sure many of your babies had. And then you've got the varying degrees of abnormality that we see in DDH. So DDH is not one single disease. It's a spectrum of abnormalities. And it ranges from what we call dysplasia, so some abnormal changes or an underdeveloped hip, through to a completely dislocated hip, where the ball is not sitting in the socket. And each of these tennis balls and teacups give you a bit of an idea of what's happening in the relationship between the ball and the socket. So type 1 on the left, that's a normal hip. Your tennis ball is sitting perfectly in your teacup. In type 2s, which can be broken down further from type 2A right down to type 2D, and we won't go into that in too much detail, you're getting some changes where in the mildest form, you've got an underdeveloped cup or an immature cup relative to the baby's age, through to the first stages of dislocation where the ball is still within the cup, but it's not sitting centrally, it's not sitting exactly where it should be, through to your 3s and 4s where your ball and socket are not interacting as we would expect. So we'll go through these in a bit more detail. So type 2 hips can be subclassified through A to D. The type 2As, so the mildest form, are just considered immature. So you've got a little bit more cartilage where you would expect bone to be. So they're not quite where you'd expect that child to be based on their age. And most of these hips don't actually require any treatment at all. The vast majority of them will just catch up completely on their own. And that will take you through to type 2D hips, where the ball is not sitting centrally within the socket. And that means that there's increased pressure being put on that outer cartilaginous bit of the hip, and that's causing some of that cartilage to misshape and to sort of head upwards. In type 3 hips, so a little bit worse again, these hips are considered dislocated. So the ball is no longer inside the cup. And as a result of that, the cup is not forming around the ball shape. So this brings us to something that's really important to understand within hip development, which is that the ball develops in response to the socket, and the socket develops in response to the ball. So as your baby or your child grows up to become an adult, you increase in size, you grow from those growth plates, And that ball is knowing what shape it needs to be becoming in response to the socket. And the socket knows what shape it should be becoming in response to the ball. So their growth and development is dependent on each other. And in this stage of DDH, where you haven't got the ball sitting in the cup or the ball in the socket, your socket starts to misshape as a result. So you've got this cartilage going further upwards, and the whole socket is becoming shallower and wider. And type 4 is just a further progression of this. So this is the most abnormal hip. This only affects about 1 in 1,000 babies. And in this hip, the ball, so the end of the femur, the femoral head, has gone so far up that it started to push that cartilage into the socket. And your cup is virtually now a saucer. It's become really quite shallow and quite wide and misshapen. So this is an X-ray. So this isn't what we would do for a very young baby. But if you had a child that presented a little bit later with DDH or is later in the process of monitoring, they might get an X-ray. But I've picked this to show you because it really nicely demonstrates. Here on this side of the screen, you've got your gap, which is not showing up on an X-ray, but in that space, there'll be the cartilage where the growth is coming from. And you've got your socket here, and that's lovely and round. And you've got a lovely, nice, round femoral head sitting within it. So that's normal. And you've got the growth plate here on the femoral side, which again is cartilage. So it is actually connected to the thigh bone. But on this side, you can appreciate that the socket is much more open. It's more shallow, it's wider, and the head hasn't developed like this one has in response. And I've sort of put in red there the angles on just to demonstrate that a little bit more for you to see that that's not sitting where it should be. It's not contained. So what is DDH? We come back to that question again. So I would say that DDH is a spectrum of abnormality affecting the hip joint. It ranges from dysplasia, so that's immature hip development, through to complete hip dislocation where the ball isn't sitting in the socket. And so how do we know if a baby has DDH? So every baby that is born undergoes a newborn hip examination, and that is part of the newborn and infant physical examination, and that's a national screening programme. And at that point, so that's within 72 hours of birth, so usually it occurs within a hospital setting. And at that point, a clinician will examine the hips just as they do here. So they will bend them up, push them down, bring them out, push them in. And they will also consider any risk factors. So big risk factors are family history, that is a major one. If the baby has been breech, so feet down rather than head down. Things like if mum has had too much fluid around the baby, things like multiple pregnancies, so twins, triplets, and there's a relatively long list. And if anything is considered abnormal, so any risk factors are flagged or the clinician isn't happy with the hip examination, then that baby will go on to have an ultrasound scan. So that's a jelly scan, like the scans you have when you're pregnant. And they will put them into certain positions to obtain these pictures, and they will grade the hip accordingly. If there's no concern about the hip, then the baby will be discharged and the whole process will be repeated at 6 to 8 weeks. That's usually done by your GP or your health visitor. If there's no concerns about the hip, that's you discharged from official hip screening. But if there are concerns, again, you'll have an ultrasound scan. So that sounds great, doesn't it? But there's a but, and it's a big but. And that is that our current screening programme is missing more babies than it's detecting. So we currently miss 6 out of 10 babies with DDH through our screening programme in the UK. And why is that a problem? So why do we want to identify this early? Well, we want to identify it early. So an early in my mind is within 12 weeks. And the reason for that is that 90% of babies can be successfully treated in a harness, such as a Pavlik harness or a rigid removable splint, resulting in normal hip development if we detect them within that time. So how do we treat DDH? So the principle of treatment that the main thing that I want you to take away and to understand here is that the ball develops in response to the socket, and the socket develops in response to the ball. So the goal of our treatment is to get the ball back in the cup. Because as that baby grows, we want that perfectly sized cup to grow to that perfectly sized tennis ball and to get that hip joint that moves nice and smoothly with a central ball that's the right shape for the cup that it sits in. So if babies are identified early, so less than 12 weeks, the vast majority can go into a Pavlik harness. Sometimes that's a different type of brace, which is a kind of removable firmer plastic brace. Most places in the UK are using the Pavlik harness. Now, all the Pavlik harness does is it holds the baby's hips in a position where the ball is sitting in the socket. And it gives that baby time for the socket to develop around the ball and the ball to sit nicely within it. And the vast majority of babies that are put into this device will normalise. Now, the slight caveat to that is that for a Pavlik harness to work, the ball has to go back into the socket. So if you have a type 4 hip, which is a completely dislocated hip, like we talked about earlier, and when we as clinicians move those hips and put them into a Pavlik harness, if the ball still doesn't sit in the socket, which is unusual if the baby's very young, but does happen, then we'd have to do something else in order to get that hip back in. So sometimes, if we can't get a dislocated hip back in the cup, the baby will go straight into a Spica cast. So usually the baby goes off to sleep for that under a general anaesthetic. We can use imaging in theatre to make sure that that ball is sitting in that socket, and then we can hold them in the plaster trousers, which is a much more rigid thing. And so you know that that ball is sitting in that cup a little bit more reliably than you would perhaps with a Pavlik harness, because a Pavlik harness might come off for an hour a day for you to have a bath and then you put it back on, whereas a Spica would stay on all the time. So just for anybody that has not experienced this with their child and doesn't know what this is a plaster cast, basically, like what you would have if you broke your arm. And it's like a plaster trouser that the baby will wear. And usually the hips are held out in that same position, nice and wide. The ball is back in the socket. And then a opening will be made to make sure that the baby can be sort of cleaned for hygiene purposes, but that this stays on all the time. It can't be taken on and off like a harness can. So what if all of that fails? What if that fails and you can't get the ball back in the socket, or your baby presents late with DDH? Perhaps your child is no longer a baby, and that I've even come across children at sort of 8, 9, 10 coming in with DDH. What happens then? So at that point, obviously, they're far too big to be wearing something like a Pavlik harness. And also they've kind of, certainly if you were talking about a child who's kind of 7 or 8, they've gone past that stage of development where a Pavlik harness would work, because it's not just the bones we need to think about, it's the soft tissues as well. So your muscles, the ligaments, things like that. If they've got used to the hip in that shape, it's not as straightforward as just putting a harness on, because there's other structures around that we need to consider. So the principles of treatment stay the same, and that is that you need to get the ball back in the socket. But if you've let's say for argument's sake, this is an 8-year-old, got a bone that's already developing with a cup that's shallow and wide, even if you put that ball down here, that cup isn't going to contain that hip. So imagine it's like putting our tennis ball on a teacup. You know, it's not on the teacup saucer. It's not going to contain it like a teacup would. And so at that point, we need to talk about osteotomy. So osteotomy comes in lots of different forms. And osteotomy basically means making cuts in the bone to reshape the bones that are there. There are different types of osteotomies that can be done depending on your child and depending on their development, their age, their anatomy. A common operation that is done is called a Salter osteotomy, and that's what you're seeing here in this infographic. So a cut is made at the top part of the pelvis, and some bone graft is placed in that, and that brings this top bit of the cut down to create a more rounded, closed cup to put the ball back into, and that's held in position, usually with some threaded wires that come out once the bone has healed. And that bone will heal like a fracture would. Now, not every baby with DDH has to go through this. And in fact, many babies, 90% in fact, if they're detected early, are able to have a Pavlik harness, and then they will go through completely normal hip development. So why are we so bothered about this? Why do we want to make sure that we're getting our babies to have their balls perfectly fitting their cups? Well, it's because we want that hip to move nice and smoothly. Because what happens when you get a misshaped ball and a misshaped socket is that you get abnormal wear. It rubs. So an analogy I would use is that if you had a pair of shoes that fit you perfectly, they're comfortable, they allow you to walk about. If your shoes don't fit, they rub and they give you blisters in different places. And it's sort of the same when you talk about a hip. And if you have really abnormal rubbing, you get increased wear. So that lovely cartilage that you have that allows smooth movement of the hip, so much pressure is put on in certain points of the hip that it wears away very quickly. And that causes arthritis. And what we know is that DDH is the leading cause of hip replacement in under 40-year-olds. A third of hip replacements in under 60-year-olds are caused by DDH. And 1,500 hip replacements are done every year for failed DDH. And that's potentially in people, you know, really young people in their kind of early 20s. And of course, that comes with its own set of difficulties, because if you have a hip replacement at 20, that might serve you really well for 15, 20 years, but then you're only 35, 40, and then you're talking about revision hip replacement and so on. And so we want to catch babies as early as possible and treat them as well as possible while that hip is still growing, still developing, still changing shape, so that they can go on to have a normal hip joint. So I'm going to talk a little bit now about DDH research. So there are lots of things that we do know. We know that if we can catch these early, the vast majority of children can be managed successfully in a rigid removable brace or a Pavlik harness, usually for about 6 to 8 weeks, but often that can be significantly longer. And then they go on to have a normal hip development. And we also know that dislocated hips have to be relocated. The ball develops in response to the socket, and the socket develops in response to the ball. So it's really important that we get those two back together. But there are still things that we don't know, that we don't have good quality evidence to tell us what the best practice is. And certain doctors are asking, should actually every child have an ultrasound at birth? Should every baby born get an ultrasound so that we detect these hips early? Another question being asked is, okay, you have your baby, you pick them up at 6 weeks, they go into the Pavlik harness, and by 12 weeks, that hip's looking lovely. It looks perfect. Everything's gone back to normal. So do we just stop the Pavlik harness? Or do we then wean them out? Do we only go to nighttime wearing for a period of time? Do we reduce it down from 23 hours a day to 20 hours a day to 15 hours a day to 8 hours a day? And what we also don't know is, what about those 2A hips, the hips that are just a bit immature, that aren't quite where we're expecting them to be? Should we treat those, or should we see how they develop on their own? So one of the big questions I'm wanting to answer in my research through my PhD is, should we wean out of a Pavlik harness? People who say yes, we should wean, say, look, there's no harm in the Pavlik harness. It's a pretty benign intervention. The families are used to it already. And if we just whip it off, then we could lose all that gain we've got within the hip development. We could go back a step. Why would we do that so suddenly? Whereas other doctors will say, it's unnecessary. You've got the hip to where you want it to be. It's now progressing as normal. And by keeping that child in that Pavlik harness, you're putting an unnecessary additional burden to that family and that baby. The question of, should every child have an ultrasound at birth? Well, people who argue that they should would say, yes, it's a relatively harmless test. There's no harm to the baby. We'll pick up much more. Currently, we're missing more babies than we're detecting. But opponents of it would say, well, ultrasounding 500,000 babies a year is going to have a huge cost implication for the National Health Service. Who's going to scan all of these babies? Where are the clinic rooms? What's the logistics of that? Because it takes quite a skilled person to do this ultrasound. How are we going to train them? How are we going to recruit them? We're also not sure about some of these hips that are a bit immature. We know that with the kind of earlier underdeveloped hips, about 80% of them will normalise on their own within 4 weeks. And are we risking over-treating and putting all of that worry and burden on families, when actually, if we just left them alone, they would have normalised? And then that comes back to this question of, should we treat the borderline hips? Should we treat those hips where the ball is sitting in the cup, but the cup's just not quite where we're expecting it to be, it's immature? And some doctors would say, yes, let's get them early. You know, let's give that baby the best possible chance of catching up, of getting a normally shaped ball and a normally shaped socket. A Pavlik harness is reasonably harmless. You know, let's just do it. What have we got to lose? But others would say, it's unnecessary. You're over-treating the family. You're putting the family through the burden of treatment, of clinic appointments, of worry, of all of the things that come along with harness treatment. There's a cost to the family, there's a cost to the baby, there's a cost to the health service. And there's all the logistics associated with that as well. So that brings me, I don't know if I can move that out the way for you all. There we go, to SmartFin IP. So I bet you're wondering, what is SmartFin IP? So SmartFin IP is the electronic record that every baby born in England is now being enrolled onto. So in England, wherever you are in the country, when your baby is examined in hospital and when your baby is examined at 6 to 8 weeks, they're placed onto NIPE. And NIPE records the results of the clinical examination, it records the results of the ultrasound, and it records the treatment of the baby. And so it is a massive, massive database. And we need high quality research to make sure that we're doing the best thing for babies. And I think SmartFin IP is the way to do it. Can we use this huge database that's already being used by clinicians to understand what's happening to these babies and what is best? So what's my PhD? Well, my PhD is working out that path towards the DDH trials within SmartFin IP. How do we do it? How do we recruit families? How do we consent the families? How do we extract that data? Is it possible to randomise babies within it? So we already know that there's different things happening across the country. We know that some babies are having weaning of their harness, some babies aren't. And can we say, right, well, we're going to randomise some babies. So some babies would have weaning and other babies wouldn't in a more controlled setting. And we would see whether one fares better than the other, or whether actually there's no difference at all between the two. And so why are we putting families through that unnecessary treatment? So there's different parts to sort of walking this path. There's different things we need to think about along the way. And from working with families, chatting with families, from working with the Steps charity, it's been clear to me that we're not necessarily thinking enough about what's important to the family through all of this. A lot of questions that we have as doctors are very focused on the medical side of things. And should we wean out of a harness? Shouldn't we wean out of a harness? We think it's a fairly benign thing. It's unintrusive to wear a harness. But chatting with families, I've understood that harness treatment has a huge implication for them. They can't get clothing, they struggle with car seats, they struggle with prams, they struggle with breastfeeding, they struggle to bond with their child. Their child is slow with developmental milestones. They have a cost implication to getting to and from hospital visits. They struggle with childcare and nurseries accepting them. And so what I want to do is develop a family-focused set of outcomes that is used within all future trials. So I want to do that through surveying families to understand what's important to the family unit during the brace treatment for DDH. So that involves a couple of online surveys. The first is one where you'll just tell me what's important to you. You know, what did you struggle with when your child was in a brace? And then there'll be a two-part ranking exercise online where you tell me what's most important. So was the disruption to their sleep more important than the difficulty you had breastfeeding or bottle feeding? And then we'll have a consensus meeting of some patient representatives, some doctors, some healthcare professionals like physios, and we'll come up with, based on all of that information that we've been told, a core outcome set. So that might be, we determine through all of these surveys that the most important things to families are difficulties they have equipment, difficulties with breastfeeding, and difficulties with bonding. And we embed questions about that within the care for these families so that when we're making an assessment of a treatment, we're also taking into account the impact on the family. So for me, as I head towards, hopefully, undertaking a trial of whether we should wean out of the brace, what I want to understand is if weaning out of the brace has a relatively small medical benefit, but has a massive impact on the family because the family have to go through an extra, let's say, 6 or 12 weeks of wearing that brace, that we've considered that when we're designing gold standard treatment pathways. And that leads me into the second part. So I'm going to undertake something called a discrete choice experiment, which is a fancy way of basically saying that I'm going to present families with theoretical scenarios and ask them to choose between them. And the purpose of doing that is so that I can really understand what the parent preferences are about different weaning regimes. So what we know at the moment is that people are doing different things. So some doctors are weaning the babies out of the braces by saying, just wear it at night time. Others are saying, just wear it for 15 hours a day, then just wear it for 5 hours a day. And others are not doing it at all. And what I want to understand is it easier for the family if you just wear it at night rather than wearing it for 15 hours a day? And actually, do families feel better about weaning because all of a sudden they're worried that their baby's going from a harness all of the time to not in a harness? And I also want to understand parental attitudes towards risk. So if the risk that your baby's hip starts to go backwards is 0.01%, but it needs an extra 12 weeks in a harness, do you want that? Or actually, would you say that's a very, very small risk, and I'd like to take my baby out of the harness and just to get going? And then I want to undertake a small study of weaning versus no weaning of successful brace treatment. So that will look at babies who've been treated in a Pavlik harness where the hip is normalised, and some of those babies will go through a weaning regime, so the harness will be reduced gradually, and others will have the harness removed completely, and we will compare the two. Now, this is already happening in clinical practice because people are doing different things. And so what we want to do is undertake this in a formal way so that we can determine what is best, and then we can standardise that across the country to make sure that every child is having what is best. So does anybody have any questions? I know that some questions have been emailed, and I think Jacqueline is going to ask some of them.
Okay, thanks, Joanna. The questions I've got here are, we've received a question from a parent of a 2-week-old diagnosed with DDH who has been told they cannot fit a harness immediately. Is there an age where it is too young to use the Pavlik harness? And also, is delay in its use associated with any increased risk to the hip?
So it's really difficult to answer specifically, because obviously every situation and every child is different. And there are scenarios where a doctor might want to delay brace treatment. So they might be things like if your baby is born premature, so the hip development is abnormal for a 2-week-old, but your baby was 6 weeks early, then perhaps their hip is exactly where it should be. It's just that your baby has been premature. Also, if your baby is detected very early with a kind of underdeveloped immature hip, so the sort of 2A, 2B type hips, we know about 80% of those will catch up on their own. And so it might be that that clinician thinks, right, we're just going to monitor this baby really closely and then initiate Pavlik harness treatment if they don't normalise. There isn't an age per se that it is too early to start Pavlik harness treatment. And in many ways, the earlier the better. However, there are some caveats to that that will be specific to your baby and your circumstances. So it's best to go with and talk to your doctor about your individual scenario.
Okay, another question is, given wait times are common, is there anything that can be done by the parents to help their child's hip condition while they are waiting to have an operation?
So I suppose the best thing that you can do is trying to keep the baby's hips in like a baby safe position. So that's the kind of M type position. So most baby carriers and things now hold the baby's hips in that position. So the baby's knees would be bent and would be up, and the hips would be out to the side. The most stressful position for a baby, particularly with DDH, that we don't like is a baby whose legs are very tightly together and straight out. So that kind of really tight swaddling with a baby sort of straight out, we would try to avoid that.
Some parents are concerned about misdiagnosis and ask, when babies are checked before leaving the hospital, is it possible that hip dysplasia is not detected? And if so, will this be detected at the 6-week check?
It is definitely possible that they're not detected, and it is definitely possible that they will be missed at the 6-week check. And we know that we're currently missing more than we're detecting through routine screening. And I think we need to look at our screening programme. We need to decide whether or not our current screening programme is correct, whether or not we should be doing ultrasound. And I know that there are people working to get a trial like that up and going. I know that NHS England are absolutely on board and have been working to try and answer that question and see what we can do better. But my advice to you as parents would be trust your instincts. And if you have any concerns about your baby, if you feel that their legs are different lengths, if you feel that your babies, when you bend at their knees and you open them out, that they don't open or that they don't open symmetrically, if you can hear clicking, if you can hear clunking, if you know that somebody in the family has a DDH, then you speak to your health visitor, you speak to your doctor, and you get that baby an ultrasound.
Next parent is getting ready for their daughter's DDH surgery and is anxious about the setup in the home. Do you have any tips on what a toddler might need support with after a closed reduction surgery? And also, is there advice if all bedrooms and toilets are upstairs only?
So I'm presuming that the child is going to go into a Spica cast if they've had a closed reduction. So I am aware that I think it's Mum Boozy, I'm sure it's on the Steps website, that there is a company that provide car seats. Now, whether they include spikers or whether they're just harnesses, I'm not 100% sure, but it's definitely worth checking that. I know from discussions with Miranda that I'd had earlier in the week that there is a company called Erin's Chair that are doing a chair basically in your house that a child in a Spica cast can use and sit in. And I think M&S have got a special range of sort of clothing that you can, you know, put your baby in when they're in cast, because I know these things can be really, really challenging. A baby in a Spica cast should not be in pain particularly. I mean, if they've had a closed reduction, that would imply that they're not having a major kind of pelvic surgery. And if they are, obviously there's analgesia and, you know, pain relief that can be utilised. And then it's just working with the specialist nurses who'll help support you, and the OTs. They can advise you on equipment, on if you notice any skin irritation around the Spica cast, what to do, who to call, help you with hygiene things. And I suppose utilising the Steps charity, I know they've got lots of fantastic resources on their website, and they've got advice from parents that have been through that.
Okay. If my child is older, in this case 7 years old and not so easy to carry, will the hospital provide a wheelchair after an open reduction? And also, what is the option to help make it more manageable to get her around the house and out and about, as she's too big for a pram, a car seat, and too heavy to lift?
So that's a difficult one for me to answer, I'm afraid, because I think every hospital is different. I think many hospitals do provide wheelchairs, and certainly for children. And if they don't, I think there are places that you can hire wheelchairs from. But I think, again, the Steps charity are a great resource for providing signposting and information as to best places to go in order for practical stuff and wheelchairs and things like that, other parents' experiences.
Okay, just going back to the Pavlik harness, is this fitted over a vest or directly onto the skin? And once they're in it doesn't make a difference as the harness seems to irritate the skin.
So different hospitals fit these differently. The one I'm currently working in do fit them over a vest. And I think if your child is having issues with skin irritation, then it's definitely worth chatting. It's usually a kind of specialist nurse or physio that's involved in the Pavlik harness fitting and chatting to them about that, because it may well be that you can have some sort of padding or wear it over clothing to try and get them more comfy. It's very well known that one of the complications of Pavlik harnessing is skin irritation, and I suppose it's just how we can best manage that for your baby.
We also have a lot of questions about how to treat a child once they're in a cast or harness. Is there guidance on the use of slings or carriers if a child has DDH? Is there any guidance on these, or should they be avoided?
Again, it's relatively difficult to answer on a kind of general level. Many baby slings and carriers now are baby safe, hip safe. So it's just working, looking into the sort of guidelines of that sling. The safe position is the end position that I talked about before. And as long as your baby is being held in that position, then that should be okay. Obviously, if the baby's in a Spica, whatever position you are able to hold that baby in that's comfortable for you, the Spica is it's a fixed thing. So the carrier is not going to bend the Spica. So that's it. It's just whether it's comfortable for you and you not hurting yourself in the process, because they are quite heavy. But yeah, the position you want to avoid is a carrier where the baby's legs are extended, so not bent up, straight out, and the legs are together. That would be a position to avoid.
Okay. When a child is in a Spica cast and the legs are straight, is it difficult to find a suitable car seat that she can use? She is 3 years old, and are there any suitable alternatives?
I think it can be really difficult, yeah, and certainly from the provisional chats that I have had with family members about DDH and the difficulties they faced, equipment is something that has come up time and time again. I think, again, Steps are a fantastic resource. They've got lots of parents with lots of experiences, tips and tricks about things that have worked for them, things that they've used, please, another plug for me, but get involved. Tell me what's been difficult for you guys, and then we as clinicians are making sure that we're considering you and the family unit and the things that matter to you on a day-to-day basis when we're making decisions about what gold standard treatment is.
Okay. The question is, my son will be in a cast for a few months after his operation. I'm not sure how to manage this. What do I do if the cast gets wet or if his skin turns red around the cast?
So every hospital will operate differently, but there should be somebody that you can call and that you have that number and access to. These are really common things, and basically the advice is just to seek help from whoever is appropriate. Usually, as I say, it's a specialist nurse or physio that's kind of involved with this, or it might be your consultant. In a Spica, if it's digging in, we need to know about that in the plaster room, and we will either cut the Spica or put additional padding on. And if it gets wet, it might need changing. So yeah, just alert the appropriate person at your hospital and make sure that when you discharge that you know who that is and how to contact them.
The next question is from a woman who has had DDH in childhood. She asks, is it normal for women with DDH to have more difficult and painful pregnancies?
So I suppose there's two answers to this. The first is, as we discussed, if you've had DDH which has been not not successful in its management, then it may be that you're getting hip arthritis early, and that often presents as kind of groin type pain, and that may worsen with pregnancy, because obviously pregnancy is putting additional weight and load through your hip and back and changing the way you walk and where the hip pressure may be going through in the hip joint. In regards to, do people who have had DDH have more difficult pregnancies, and is there a correlation? I think, as far as I am aware, that research has not been looked into. So I don't think there's any known connection between the two, but whether you could say definitively, somebody would have to investigate that. But I suspect it may be due to some early hip arthritis.
Another parent's asked, myself, my sister and my son have all had treatment for DDH. I am interested in the hereditary nature of some forms of DDH. We have all been treated, but I noticed that in my son's paperwork, it mentions that we should tell him to ensure his own children, should he go on to have any, should be checked for DDH. What is the probability of DDH for such examples, siblings, children, etc.?
So DDH has a genetic component, definitely. And different papers, research sources will tell you different figures. The figure that I have seen sort of most reliably quoted is that you have a 12 times increased risk of DDH if you have a first degree relative with it. So first degree relative would be a parent or sibling. So any child born with a parent or child with DDH, I would even go so far as to say, you know, aunties, uncles, you know, people in your close family should be having an ultrasound of their hips early. So yes, there is a connection, and yes, they do need investigating.
Okay, we've got another question. My son has a severe case of DDH. The left hip is subluxated, was dislocated. He has never walked or stood only in a standing frame and is 6. He was found to have a rare neurological disease age 3, but his physiotherapist is still adamant his severe DDH is the reason for lack of mobility. Can this be true?
So it's really difficult to answer kind of specific questions, because obviously there's lots of pieces of information that would feed into that in terms of where your child's hip development is now. If they've had a successfully treated DDH and the hip is developing normally, then I would not expect that to be the cause of any mobility issues. And certainly I have seen children walking, admittedly with a limp, but walking in, you've got a completely dislocated hip at kind of 7 or 8, and actually even older. So never walking at all because of DDH would be unusual. And again, without the kind of information about the neuromuscular condition, I can't really say, but it might be lots of factors all feeding in.
Okay, well, thanks, Joanna. That's the end of the questions. And thanks everybody for attending, and Steps Worldwide for making it happen. The invite to participate in Joanna's research will be shared through Steps and in the webinar follow-up. So thank you, everybody, and have a good evening.
There's a QR code on the screen now. If anybody could scan it, it will take you to a link for some feedback, and also give the option to provide an email if you would like to sign up to take part in any questionnaires for my research. Thank you.
Thanks now. Bye.
Bye.